I'm sure after that session there must be some questions for our two speakers. Yes.
Thanks, Charlie Hardy here. In context of open disclosure and assisted decision making, could you talk a little more about fostering a culture which makes it easier for everyone to talk to patients appropriately and with maximum empathy as early as possible after an adverse event?
I think that there are some difficulties around open disclosure sometimes in the immediate aftermath of a clinical incident. Quite clearly, immediately afterwards, it's often very difficult to give any kind of reasonable explanation for what has happened because there may be complex clinical factors involved and so on. So it's not an easy process, Charlie. But there's little doubt that where we have been in Ireland so far, where it has been effectively a culture of not saying anything to the patient or very little in the aftermath of something going wrong, is completely unacceptable. At least we can say something went wrong. We're not quite sure what actually happened, and there will be a process here. And I think it's that process which I think is going to be the most significant added value issue to the whole open disclosure project, which is about that initial engagement and then the continuous engagement. And I don't know if you've seen the proposed legislation, but the process as laid out is, a particularly onerous one for hospitals and practitioners, but fair to patients and fair to clinicians and nursing staff generally.
John McPhillips from the Bon Secours Health System. A question for you, Paula. Given the leadership challenges that you've outlined there, I'm just wondering from your experience in other jurisdictions, what has helped bring about that paradigm shift that you'd like to see?
Well, I would probably have to admit that we're not seeing enough of the paradigm shift. I think what I described there is kind of the vision and the future state. I think today, if we were doing, this is my opinion and observation, if we were doing more in the area of creating culture where people are comfortable talking about mistakes as process errors and not blame, we wouldn't be in the situation with the numbers that Karen presented, and the numbers in the states mirror that perfectly. I mean, just in terms of the types and everything. So I think the whole notion of understanding highly reliable organizations, and it's really great. We didn't really coordinate, but we were perfectly coordinated in a lot of ways, to try to understand the characteristics of organizations that have almost zero harm. That's what our current discussion in the States at the Joint Commission is can we even imagine zero harm? And the great comparison is thinking about the airplanes, the aviation industry and the healthcare industry. And there's what they did, there's still human beings that run the aviation industry, but because they had so much publicity around crashes, particularly beginning in the 1970s, and some of this even goes before that, and the pilots die, and I think that's a piece of that. But the industry really, like others, like nuclear power, started to think about what do we need to do to have zero harm, to not have these errors. And I don't think that conversation has really started yet. In the States, we're starting to see, because we're talking about it and other organizations are talking about it, there is an interest now in high reliability. And the characteristics that were on Karen's slides are exactly what we're all talking about. But we've kind of gotten it down to leadership taking responsibility and owning the responsibility for creating that culture. And then we believe that all of this is based on process. So really diving into those processes and understanding what are the mistakes we're making in the process as opposed to the human error. I'm not sure, I can't point, one of the weaknesses of all of this, or not weaknesses, but one of the frustrations, I cannot tell you a case study about a hospital who's really done this well. There's one, Memorial Hermann in Texas, and this always happens. They had a huge Sentinel event. This was about maybe even 10 years ago, and it hit the papers. And so a very famous hospital, it's not a secret, they killed a patient, as I recall, and it made the headlines in the local newspaper. And that was their wake-up call. They said, this is not going to happen here again, and they changed the whole culture of how they ran that hospital. And I've had a chance to meet the chief medical officer that was responsible for a lot of those changes. And he tells a great story about wanting the surgeons and all the physicians, not just the surgeons, to use, and I'm not a clinician, but there's a way to insert a central line using a scanner, you know what I mean? As opposed to just eyeballing, putting the needle in, to use a scanner so that you have a much more accurate insertion of the needle. And this is the story he tells doctors, so I'm copying it. And so he said, that's the way we're doing it now, because you don't have mistakes that way. You can actually see where the needle's going in terms of going into the patient's arm. And he had one doctor left that wouldn't do it. And they got into a big fight, and a classic doctor fight. I've been doing this 20 years. I know how to do a central line insertion. I don't need you to tell me how to do that. And Mike Chabon, his name is, C-H-A-B-O-N, he fired the guy. He said, you're either gonna leave, you're not gonna be here anymore, or you're gonna do it the way we're all gonna do this because it's safer for the patients. So, that's one example. So there's like 1,000 of those that you have to take care of to start to get the culture moving. But once your staff sees that you were willing to fire that surgeon because of the patient safety risk, that is so valuable, because it's such a lesson that you teach as a leader when something like that happens. And you talk about it. You don't even keep that secret. And the other surgeons certainly did talk about it. And so step by step, and they actually are not fully high reliable, I don't think they'd argue that, but they go now months and months and months with no hospital-acquired infections. And we know that because they're working with our research department and using some of the infection control tools that are now available internationally to hospitals that are accredited to track things like hospital-acquired infections. And when you see hospital-acquired infections go down, which they did, then they see their money go up. And just what you were talking about, it's very interesting and very exciting. And I think we are at the beginning of a lot of hospitals starting to talk about it. I do a lot of speeches now, and it's interesting to me today that Karen talked about high reliability. That's a signal that it's much more in the environment than even 5 years ago.
I think that we've probably run out of time. I'm sure there are more questions. Maybe you'd like to address the questions to our speakers over coffee. So it's coffee time now, and we start at 11:15 on the dot. And I'd like to thank our speakers again for a wonderful session.